speech and language therapy. Now we have chiropractor. Both are most welcome.
Good morning. My name is Charles Sayumbe, Member of Parliament, Koboko Municipality, and I chair the Parliamentary Committee on Health. Thank you.
Thank you for all the introductions. We can see that we have a wealth of experts in the room, and we look forward to a lot of sharing and wisdom. At this moment, we want to invite our country director, Mr. Sam Tukey, to give us opening remarks. Thank you.
Good morning again, ladies and gentlemen. I would like to begin by recognizing all the protocol, the chairperson of the Parliamentary Committee on Health, all the honorable members of Parliament present here, all the presidents of the different rehabilitation fraternity in the country, our colleagues from the development partners, and other stakeholders that are represented here, we not list individually, as well as the media. Once more, my name is Sam Tukey Ojuro. I work with the USAID Learning, Acting, and Building for Rehabilitation in health systems. In short, you can note from the communications we have been sending, we abbreviated as RELAB-HS. So that's the RELAB-HS in full. So I'm going to just give a brief of RELAB-HS. Learning, Acting, and Building for Rehabilitation is a consortium of 5 international organizations. It's led by Johns Hopkins International Institute of Research, International Injury Research Unit, based in the US. The background to Professor Kida, you're most welcome. The background to rehabilitation is one of the unique activities that the USAID has funded, but also globally, that focuses on rehabilitation. Like our colleagues will be giving us the background here of the state of rehabilitation in the country. That is a growing area of interest and an area that affects all of us. It doesn't segregate children, because even if you have survived it at some point, you might still find it at old age. So we all need to understand, especially the current growth of, is to work with different stakeholders and the government of you that are responsive to rehabilitation, growing rehabilitation needs in the country. To be highlighted here. We are all aware, most of them are coming from the non-communicable diseases. We have stroke, we have cancers, there's so many, the statistics in the country is growing so much. So we like to make sure that the healthcare system is responsive to what is a growing need in the country. But also, we might be ranking one of the countries where accidents are now becoming a very prominent cause for a need for rehabilitation in the country. When we made a visit to one of the districts in the Busoga area, the statistics of the district for a quarter, accidents were now prominent, I think coming maybe number 2 or 3 to malaria. So it means it is beginning to rank so high, and yet our systems of healthcare are not adequate enough to respond to to respond to those needs. So as Relab HS at a national level, we are working with the Ministry of Health. First, to see that the policy framework supports the strengthening of rehabilitation services. We are currently, together with the Ministry of Health and other partners, supporting the development of a national rehabilitation strategy. So because in the absence of a strategy, there is no framework that's going to support the strengthening, the integration of rehabilitation across the healthcare system. But also, there has not been information that is to inform the government of the state of rehabilitation. So some of the information that will be shared here today is part of the information that has been collected, that is highlighting what exactly is the state of rehabilitation and what the rehabilitation needs in the country, but also globally, how are we ranking in terms of rehabilitation. At the regional level and the district level, we are also working with the primary health care system to test Hello? Yes, okay, to test the models that are able to strengthen integration of rehabilitation within the primary health care systems at that level. Because we are all aware that it is only regional referral hospitals in the country that have rehabilitation workshops where you can have a rehabilitation device either modeled or provided at that level. When you go to the lower facilities, you would hardly find a rehabilitation professional in the whole district hospital. You might find one orthopedist, but you might not find all of that you might get. But again, with the growing population, means our people actually go to those facilities, but they're not able to get those services. So when they go upwards to the regional hospitals, they might not get all the adequate services that they require. And then they resort to private sector. The private sector is very expensive. For instance, you go to KOSU, you pay very dearly. Not many Ugandans are able to pay for such services. So why you are saying that, can we engage all the different stakeholders in the country so that we begin to ensure that our systems, our healthcare systems, starts to invest for rehabilitation, just like any of the other pillars for healthcare. Because in terms of universal healthcare coverage, the pillars include prevention, care, treatment, palliation, promotion, and rehabilitation. So when you rank them, rehabilitation has not gained space just like prevention, the treatment, and we are happy that of recent promotion, health promotion has gained ground in the country. So we want to see how do we put efforts to ensure that rehabilitation gets that in terms of financing, in terms of human resources, in terms of the national capacity, in terms of the national planning, so that we are able to have that the services for rehabilitation are available. So the introduction we had here from different rehabilitation associations. So those are the various identifiable rehabilitation needs in the country. So they are packaged into professional associations for purpose of coordination, capacity development, professional development. So one of the supports that we do as Relab HS, we work with all the professional associations together with academic institutions, like you heard from introduction here, Makerere, Kyambogo, Mbarara, Mulago itself, to support the continuous professional development for the rehabilitation professionals in the country. But also, like they will highlight, that a number of the rehabilitation courses in the country are only up to diploma level. So that means there is insufficiency of capacity when it reaches a certain level to handle the growing need for rehabilitation in the country. So the purpose of our engagement here, we are drawing together the key stakeholders that will feel that will begin to inform that journey together. Particularly, we have invited the members of the Health Committee of Parliament so that together we begin to work with you that journey of seeing that we highlight the state of rehabilitation in the country. Today we'll highlight the statistics of rehabilitation in the country. We shall also highlight the different key priorities coming from the different rehabilitation associations. They represent the rehabilitation fraternity, definitely, from different angles. Then from those, we would like to interest the members of Parliament that how do we begin to work with you as champions, to champion the cause of rehabilitation, to highlight the cause of rehabilitation in the country, to share these statistics with the House of Parliament, to have this discussed further with the Committee of Health and Parliament, to see how does this begin to be a part of the priority when you're appropriating resources at Parliament for the annual plans for government. How is rehabilitation getting relevant as well in the national budget? Because we are all candidates for it. One of the simple examples normally we can give, that we can walk out of this hotel, you miss a step, you fracture a leg, you need a rehabilitation service. So you run from here, the immediate facility cannot handle your case. You run to Kosu, their priority is sometimes more children, the adults pay dearly. So in that case, you actually missing the first primary support that you require. And yet that could be just their nearby facilities. Should be able to go to Naguru Hospital and get that service, but you might struggle to get it. So what we're saying, how do we work together with the different stakeholders, the members of Parliament, the professional associations, the Minister of Health, the different stakeholders present here, the academic institutions present here. How does the media support to profile rehabilitation in the country so that we begin to see all from one page? So I would like on this note to appreciate all of us, especially members of Parliament, development partners present here, the members of the rehabilitation fraternity, academic institutions. We had a colleague introduce some national medical stores. So Christine, yeah, she represents national medical stores. So the idea behind that, we want to see all the key stakeholders. For instance, our healthcare system only imports medicines. So all the rehabilitation assistive devices in the country are not taken care of by the government. So one of the things we are looking at which point do we begin to see that the government begins to prioritize assistive devices as part of the medical supplies that are supplied just like medicines, especially because of the growing need for rehabilitation in the country. So to walk that journey, we also need a partner like national medical stores. They're able to inform what's the flow of the medicine, what's the practicability that we can actually have the assistive devices. And then if assistive devices, what are those that are a priority in the country? That should be prioritized. We may not have all the lists come, but step by step, what will be those that are a priority we can begin to look at as a government to begin to be integrated into those that are like universal, that every community, for instance, in the country requires. So that's the background to our meeting. So the presentation from our side is meant to inform the process, but also inform Maybe on quarterly basis, I accept our invitation to walk this journey together. At different times, we'll begin discussing different things. We want to equip you with the information that you need so that you have a very informative background to engage the rest of the Parliament. And then that should be able to take us to a level where everybody begins to see it visible. We all see the same thing, and we then have an opportunity to increase the state of healthcare that is inclusive of rehabilitation in the country. I would like to end here for God and my country. Meanwhile, we did an introduction. So we have been joined by Professor Kiria, is the president of the Allied Professionals Council. Maybe you can.
Sorry, he's given me a big title. I'm not the president. See, these days you have to be sensitive with the titles. So I don't want to get into a new MK system. So, okay, so I am Professor John Charles Okiria. I'm the chairperson of Allied Professionals Council Uganda, but I'm also a teaching professor. I'm glad to be here. My background is actually Allied Professional. Thank you.
Sir, and thank you very much, our country director, Mr. Sam Tuke, for giving us a clear background of the reason we are here, and for taking us through what rehabilitation has been doing, is doing, and continues to do. So please put your hands together and we give him a hand of applause. At this moment, I want to invite another colleague. We are doing this together. I did not introduce myself, unfortunately, but now I can introduce myself. My name is Lilian Asimwe. I work with rehabilitation. And we usually say ladies first, so I was doing the job first before we bring in a gentleman. Please welcome Julius Natumanya, our next.
Thank you very much, Lydia. I think I can do away with this one. Doesn't work. But okay, thank you very much, Lydian. But also, thank you very much, Sam Tuke, for giving us a great picture of why we're here, but also giving us the objectives of this roundtable meeting. It's a roundtable, but we have sat in squared mode. That said, those that have just come in, it is very important that we have working tea because we have to manage time. We have to be done by that time that you see on the agenda. So in the event you haven't gotten your tea, I think you can kindly move to the serving table and get tea. And as you get your tea, I think it's very important also that we get a picture from Parliament. And this is going to be given to us by none other than Dr. Ayume from ladies and gentlemen, Dr. Ayume.
Thank you very much, Richard. Honorable members of Parliament, the Chief of Party of Relab HS, distinguished ladies and gentlemen in your various capacities. My name is Dr. Charles Ayume, Chairperson of the Parliamentary Committee on Health. It's an honor to be here with very important stakeholders, but yet neglected. And this is a national roundtable event between the rehabilitation stakeholders and the Parliamentary Committee on Health. And I would really want to thank the Chief of Party of Relab HS for reaching out. This roundtable discussion has been long overdue. He reached out 2 months ago, and we just were failing to find time, synchronized time where we could all meet. Because sometimes the committee is doing oversight up country and so forth. And this meeting was supposed to be last week. I wouldn't have been in this meeting, but he said, no, we want you as a chairperson around with your deputy. And from listening into his preamble and from the introductions here, I think you guided very well that I should have been in this meeting, because for me, I already see the importance of rehabilitation. Like I said, it is an area that we seem to ignore. We mainly focus on the treatment aspect, and we think somebody will walk out of the point of care and miraculously get healed. But allow me to also still introduce a member of parliament who has walked in. He's a surgeon by training. Please, Dr. Kagabo Twaha. And you can introduce yourselves. They may want to know who you are.
Thank you, Chair. Good morning, everybody. I'm Dr. Kagabo Twaha, Member of Parliament, Bukoto South, Rengo District. And you said it, and I'm a surgeon by profession. Thank you.
Good morning, members. I'm Nisima Boaz Kasarabo. I'm a member of parliament. I represent Kochi County. Kochi is in Rakai. And I have a medical background as a laboratory technician. I'm happy to be here.
Holders, Dr. Boka Didi George is my name. Member of Parliament of Bongi constituency, of Bongi district in West Nile. I'm a member of the committee. I'm a public health specialist by training. Thank you.
Yes, so pardon me, the reason why I interjected my speech is that Dr. Twaha Kagabo is a surgeon, and he very well knows the importance of rehabilitation. I, for one, had an injury. I play football for Parliament of Uganda, and arguably, I've had people in the corridors of Parliament mention that I could be one of the best footballers that our Parliament has seen, maybe in the last 30 years. So I got an injury while playing for Parliament in 2021. It was an Achilles tendon rupture. I had surgery done in Uganda, and he was my physiotherapist. I thought we shall focus mainly on the surgery, and I would be back to walking, because I was put in a cast after the surgery for 8 weeks, which is about 2 months. But I think the most important part of the healing process was the physiotherapy, which he ably did, and that's why I am able to walk. And somebody had taken over my team, but with his good care, I am now back, and I'm back to playing active football. So it just underscores the importance of physiotherapy. And I would really want to have this discussion. We are preparing for the IALA Games, which will be in December. But many times, most of us, especially when you're above 30, above 40, the of your muscles and tendons is not as somebody who is in their 20s. So before you go for, I think it's only important that you're taught how to first do a lot of exercises before even you step onto the pitch, basketball court or volleyball court, for about a month or so that your muscles get that elasticity and you're able to prevent these injuries. So we should not only look at the post-physiotherapy component of it. Sometimes we have to tell the sports people what you need to do to prevent the injuries. Most of the injuries we get, like hamstrings, adductors, and so forth, is simply because we have not put enough load on the muscles before active sports. So you have to do that a month before. Load the muscles so that when you go to the sports pitch and you try and do something, there are sportsmen who have played football until 40 years old, like Ibrahimovic. How does he do that? It's because of constant training. But for us now, between the two competitions, we have not stepped on the pitch. Then when we hear that the competitions are starting, that's when we wake up to go. And most likely you're going to get these injuries. So as we look at these national policies and strategies, how do we prevent some of these injuries? Because I think they are preventable. Dr. Touquet mentioned a number of very important things, which I really agree. The National Rehabilitation Strategy and Framework. I think we need to have that in place as soon as yesterday. Rehabilitation is a gray area that most people do not pay attention to. Even in our programming as a country, I must admit, because now I'm part of government, at the Ministry of Health level, when we are planning, we are mainly looking at the infectious component. It's now that we are starting to gravitate towards non-communicable diseases. But we are forgetting that we have to look at the entire chain, the entire value chain of rehabilitation, from the training to the cadres. Whom are you deploying? Do we have should we only stop at regional referral hospitals, or should we cascade further down to the community? Because at the end of the day, the success of rehabilitation ends up in the household. We cannot leave it only into the hospitals. When somebody goes home, you have to continue with that rehabilitation. You cannot only be going to the hospital for rehab, then you go home and you're seated in a chair the whole day until next Monday when you're supposed to go back to the hospital. So it all cascades further down. So we have to take it beyond the regional hospitals to the health centers for it to be able to succeed. NCD is good enough. We have the chairperson of the Parliamentary Forum. The success of the outcome of stroke, survivors of stroke, is rehabilitation. And I can see some of private rehabilitation centers coming up. I think there's one in Gaza, particularly for stroke patients. The question is, who regulates them? And do we have policies, strategies, and frameworks in place? Again, I'm happy that we are looking at national policy and strategy for rehabilitation. Colleagues, I don't know when the team on this side was introducing themselves, you kept on hearing of various cadres, and some of the information here sounded, I'm sure, very foreign to some of, especially the non-medical people here. We had speech and language therapists, we had orthopedic technologists, physiotherapists, audiologists, but we sometimes say physiotherapy. We just lump them, I've gone for physiotherapy. Yet somebody may actually be taking their kid for speech and language therapy. So all these various cadres have to be recognized. What they're asking for is support. It is our noble duty as the Parliamentary Committee on Health to keep on poking Ministry of Health as they are revising the structure. They have to make provisions for all these kind of cadres. Unfortunately, the curriculum is housed in Ministry of Education. I do not see Ministry of Education here, but also the sports component. They should have been here. I think recently they had the bill that was passed. I don't know if there was a component for rehabilitation. We have seen rehabilitation in mental health, which I think they are doing to a relatively good extent amidst the challenges in Butavika. So I hope you're not trying to infringe on the mandate of Butavika, because that one is for mental health rehabilitation, and let us leave that one housed there. We are looking here at more of the physical and psychological rehabilitation. As I conclude, what is the role of Parliament in all this? Of course, on the side of legislation, we have to make laws that speak to rehabilitation. I think we did that. There was a component of that in the public health amendment bill, where we put in NCDs, but of course, the Ministry of Health will make regulations that speak to that. Another role of Parliament would be on the side of the funds that we allocate to the Ministry of Health, to ensure that we look at the entire value chain of rehabilitation. Somebody made a very important call, honorable colleagues, that if we can appropriate money for ARVs, because this year government of Uganda had to front load 50 billion shillings because our good donors from ESID, the Dr. 2Ks, have said they are pulling back. We pulled back by 50 billion, we have put in 50 billion. And I think that shows the commitment of government. But if we can put money to ARVs and so forth, why can't we put money for these devices? Walking canes, bicycles, the wheelchairs, and so forth. Because sometimes members of Parliament, I've had people in the corridor, I've gone to Ministry of Health for wheelchairs. I'm not so sure if it's under the ambit of Ministry of Health to provide wheelchairs. I would think it should be under Ministry of Gender, Labour and Social Development. I think they should have also have been in this meeting. The component of the elderly, who are usually victims and clients of rehabilitation, I think they should have been a representative in this meeting. So that when we are trying to pitch some of these things in Parliament, we have the support of sports, we have the support of health, we have the support of Ministry of Gender, Labour and Social Development. Interestingly, there is also a forum on social protection. How do we help the elderly? Somebody who slips and gets a fractured hip and needs a wheelchair and so forth. If we have the numbers, then we can convince government to put some of these in the recurrent expenditure so that wheelchairs can be got from a regional referral hospital. What do you call them? Cochlear implants? Yeah? Cochlear implants. They're very expensive. So how do we ensure that they are bought by NMS? Good enough we have a representative from NMS here. Some of these should ideally be put into our recurrent expenditure. The issue of advocacy, I don't see from members of Parliament here, most of them are going to be champions, advocates of rehabilitation. I'm a living testimony of good rehabilitation services. That's why I'm back on the parliamentary team, and I'll continue to scoring goals for Parliament of Uganda and leave that legacy on the parliamentary team. We have a hospital of recent that has been in the headlines called China Naguru Friendship Hospital. China Uganda Naguru Friendship Hospital. And that's been earmarked to become our national trauma center, meaning all complicated surgery, especially after injuries, trauma, and so forth, will be done there. And I think it's a grant from the Democratic People's Republic of China, Democratic underscored, People's Republic of China. Members of Parliament, we need to take interest to ensure that this National Trauma Center is not only for surgical purposes, but there's a huge component of rehabilitation. And I think we need to start engaging Ministry of Health to look at the designs, to look at what services are going to be offered there. Because you cannot just do surgery and there's no component of rehabilitation. That has to come out quite strong. So I think you will leave that to us. We are members of Parliament, and I think we have taken interest. And from the smiles on my colleagues, I think that is already a tick. Otherwise, I thank you very much. It's an honor to be here, a privilege. And it was not by design that we had forgotten rehabilitation, but I think there were very many pressing things on the menu, like enhancement of salaries for health workers, which I think we have done. I'm sure the accounts are a bit bloated now. The issue of interns. There have been so many things we have been chasing as a Parliamentary Committee on Health, but it's never too late. I commit on behalf of the committee that we shall work together to ensuring that the issue of rehabilitation gets up to the thank I think Caroline from Chaninga. Fiona will tell her story, but she came here as a visitor and has stayed in Toro. I do not know why, but she's offering a service. She came to treat a patient, and the rest is history. She's now offering her services to a community and to different parts of Uganda. So I think she needs a round of applause. And I hope we'll get in to listen to your story and what has kept you in Uganda besides your professional services. There may be other things, Madam. I thank you very much, and I wish you fruitful deliberations.
Thank you very much, Dr. Ayume. I think it's very important that we clap hands for the commitment that they have committed as colleagues from Parliament, because and the camera should capture those hands so that we send to them, so that we remind them that they committed. And it's very important that we appreciate Doctor once again. Thank you very much, Doctor, for the wonderful remarks. Without wasting much of our time, we're going to have someone who actually advises the Relab HSC. This is our technical advisor, the one and only Gerard Okero. Ladies and gentlemen, Gerard Okero. I'm going to request that we stand here for cameras to be able to capture, but also people who are online to be able to view what we're saying here.
Thank you very much, MC. The chairperson, Parliamentary Committee on Health, the honorable members of Parliament present, the chairperson, allied health professionals, the different representatives of the rehab associations, ladies and gentlemen. Once again, my name is Gerald Okelo. I work with Relab HS as a technical coordinator. I'm an advisor. My role, I'm going to share with you the situation of rehabilitation services and AT in Uganda. Together with the WHO, we worked with the Ministry of Health and conducted a survey on the situation of rehabilitation in Uganda. This report is before the Minister of Health for signing, but we have unsigned copy for the chairperson, just for you to have a copy. But very soon we shall have a signed copy from the ministry and be able to disseminate across. So allow me take you through this. So I'm going to share the findings briefly, but before we share the findings, I would like to highlight a few things. That there is a high number of people with limitations in functioning. When we talk about rehabilitation, we talk about optimizing function. We don't look at a condition. So many people who have limitation in functioning is increasing. For example, myself, if I removed my glasses, I would not be able to function. That's a limitation. And this limitation, this limitation, all these numbers are coming from aging. Doctor talked about aging. Our population is aging, and we want to appreciate the government for improving service delivery. Because of improved service delivery, we are now living longer. Before we were 42 years, now we are at almost 62 plus. So that's already a plus for government. And because of this, other things come in. So aging is one of the reasons why we have a number of people increasing. NCDs, injuries, we know that in Uganda, in East Africa, Uganda is the leading country with the injuries. Every other day we have a lot of casualties. Apart from those who died, there are a number of them were injured and left a lot of limitations in functioning. And so that increases the number of people who need rehabilitation. I will give a global picture. Globally, we have 2.4 billion people who experience a health condition that could benefit from rehabilitation. This translates into 1 in 3. So just imagine, 1 in 3 people will need rehabilitation. That's globally. And this has increased to 63 since 1990. When we look at AT, 2.5 billion people need 1 or more assistive products globally. I will come to the Ugandan context soon. In terms of rehabilitation need in Uganda, we have 1 in 6 people in Uganda need rehabilitation. I want to assure you, among us here, we are many who need rehabilitation, but we don't know that we need it. So 1 in 6. That translates to 6.8 million people in Uganda who need rehabilitation services. That is statistics of 2019. But as of we speak now, that might be more than that. Low back pain alone carries 1.5 million people who need rehabilitation. And this has contributed to 820,000 years lived with disability. Now, the impact of these conditions is disability. If you're not able to be productive, that means that the country can also not develop. So if your population is living with disability, it means not productive. So that impends all our national plans or policies towards development. And the years lived with disability has increased by 124%. That's surpassing 100% from 1990 to date. In terms of assistive technology, the demand for AT in Uganda stands at 25.5. If we use the statistics of 2014, that translates to 8.8 million people. If we use the current estimates, that puts us at 480 million. That is 12.4 million people need 1 or more assistive products. However, only 4.5 currently have access to assistive technology. Women 4.3 and men 4.8. So you can see the margin that 21% of our population that need assistive technology do not have access to these services. So the trend, the need for rehabilitation has increased in the last decades, and it has increased by 125% across all conditions. Allow me highlight the findings from the STARS again, looking at specific areas. I'll start with the leadership and governance. I highlight the strength. We know that rehabilitation is anchored and coordinated by the Minister of Health, as responsible for legislation, policy, strategic planning, coordination, accountability, regulation, and capacity development. Also, rehabilitation is included in some of our documents, but not all of them. In some national policies, it's mentioned, but not mentioned explicitly, just mentioned as rehabilitation services. However, as a country, we do not have a strategic plan for rehabilitation and AT. We don't have AT priority list. And rehabilitation, there is lack of prioritization of rehabilitation and AT in the health sector, and planning and financing. So one thing that came out is that rehabilitation is a non-funded priority in government. And it's very important that the team that allocates the budget is here, and we see how can we start thinking about rehabilitation as a key health sector. When you look at financing, there is no strength when it comes to rehabilitation. There is nothing, like, apart from the salaries of the rehab professionals, there is no other fund given to rehabilitation services in the country. This is from the findings across the country, and so rehabilitation lacks a dedicated financing in the whole country. If you go to start from the national department, the Minister of Health, you go to the national regional referral hospitals, you go to the region for, you go to all across the sector, there is no funding for rehabilitation. And so most of the clients or the beneficiaries have to pay out of pocket. Most of them have to pay for these services. And if you know that rehabilitation is a long-term service, and if you have to pay that money alone, you may not manage to pay the full package. You will start missing some of the appointments. And the other thing is that most of the funding is coming from the donors. We have seen assistive products being distributed by members of parliament, by other NGOs, and so most of the support is rallying around the donors and out of pocket. Information management and system. So in terms of information, information is very critical for you to advocate for anything. When it comes to rehabilitation, though we have a few numbers, statistics from the hospitals, rehabilitation data is not reflected in our national HMIs. You don't see it anywhere. We don't have rehabilitation indicators. We can't even tell that in a year how many people are receiving rehabilitation in our country. So that's a very huge gap. And so it is so difficult for us to advocate for rehabilitation. So the data is not reflected in decision making because the data is not there, so you cannot use it for decision making. If it was there, then we would say that why not using it for decision making? So, and sometimes different partners use different forms of data collection, so there's fragmentation in data collection for rehabilitation. In terms of workforce and infrastructure, we are blessed that we have a number of professionals. As you heard from here, we have physiotherapists, we have occupational therapists, we have orthopedic technologists, we have orthopedic officers, we have speech and language therapists, dental technologists and technicians, audiology technologists, and ENT. All of them are in the country. However, the numbers are very low. Many of them are not in the service scheme, so they are not actually employed. They are just moving around in the private sector. Some of them are distributing drugs for pharmacy. So they are just there redundant. So that's a big challenge. Yet they are actually available. If they were not there, then we would also say, okay, we really have a big problem. But they are there. Okay? In terms of infrastructure, honorable members, if you visited some of the rehabilitation units in our country, you'd wonder who receives the services from there. We took pictures, but we are not able to show them the pictures. Right from the National Hospital in Mulago, where it was somewhere near the nurses. If you went to see the state of the infrastructure, and you ask yourself, who receives the service from here? So really, when you look at infrastructure, it is there. When you look at equipment, we are using equipment of, I think, 1990 something. Technology is advancing, but we are still using technology of 1990s. And thank you. So there is so in terms of infrastructure, we can't even talk. But if you could appreciate and see if you could just take a tour and visit some of these units, you will be shocked. They are not accessible. Just accessing them alone is an issue, because a person who needs rehabilitation may be using a wheelchair, but you find that from this point where the unit is, you need to be carried fast before you even reach the unit. So that's the situation in terms of infrastructure. Of course, the supplies. We are happy that NMS is here. There is no rehabilitation supplies or assistive technology that is currently procured by National Medical Stores. One, because we do not have the 80 priority list, which we actually are working on. So also in terms of specialization, our workforce is largely not specialized. We are providing general services because, one, we are all trained at a diploma level, and therefore we are not specialized. Yet some of these services need to be specialized. So we're also hoping that we will find ways of addressing such issues. In terms of access of rehabilitation services in the country, the services are generally available at the national hospitals and then the regional hospitals. Very little is done at the district hospitals. Where the PNF is available, there are some services there, and of course largely the private sector. And the private sector is mostly in the urban setting. Now, the people who live in the community where our population lives do not have access to these services. Many of them have to trek long distances to access the services. So we find that access, availability, accountability of rehabilitation and AT is very low. The coverage is very low. Of course, because we are not specialized, we don't provide specialized services, but our professionals try to study on their own to become specialists. Some of them have specialized in children, in stroke. If you talked about Gayasa, the stroke rehabilitation unit in Gayasa, all of them are trained at the same level, but some of them have taken interest in stroke, and so they are able to provide stroke rehabilitation. Ideally, this is supposed to be a specialized service. So we don't have service units that are specialized for rehabilitation. As a country, we don't have a rehabilitation unit or a rehabilitation hospital. Apart from KOSU, we know that KOSU is a private hospital. It's the only rehabilitation hospital in Uganda. If you go to Mulago, we do not have a rehabilitation ward. Yet Mulago sees so many patients. We hope that when we have the trauma center in Naguru, we shall have a rehabilitation ward that will focus on rehabilitation. Because rehabilitation is long term. Once the surgery is completed, the person should be discharged through rehabilitation. But this is not existing in our country. And ideally, every regional referral hospital should be having at least 2 or 3 beds for rehabilitation. But as of now, there is nothing. Maybe a few, like Gulu Regional Referral Hospital has a few beds because of funding from partners. But as government, we have not taken interest in putting these services to our hospitals. In terms of quality, it's important to note that rehabilitation services that are provided by our professionals actually restore functioning, participation, and empower users and family users. This is the role of rehabilitation, is to improve functioning, in participation, and empower the members and the family users. So this is what we are already doing. Despite us not being specialized, we are already doing this very well. The intensity of rehabilitation is low. One, because the services are not easily accessible. Many of our clients are not able to meet the appointment because of distance and also the cost. But also because we do not have rehabilitation wards where these patients can be admitted and provided with intensive rehabilitation. Of course, we mainly use improvised tools because, as we talked about tools, we do not have up-to-date equipment, so we are using whatever we can manage. And Combra here makes tools or assistive technology using locally available material, boxes, wood, just making wheelchairs using those things. But we can do better than that. When it comes to provision of assistive technology, we know that as a country, we don't have an essential AP list. However, we are providing services, some AT in our hospitals. We don't have standards on AT provision. Research and innovation is lacking. We do not have any fund that is focused on research and innovation for AT. And you know, for AT, there's a lot of the development going on in other countries, but we do not have capacity to do such research and innovation as a country because we don't have funds for that. And the other thing is rehabilitation or integration of AP in research, in rehab services is also lacking. We find that we have separate rehabilitation and we have separate AT, yet these are supposed to be together. So largely, there is lack of country-specific adapted AP list. We lack a lack of integration of AT into national medical stores, and we have that medical stores is here. Hopefully we shall have it integrated soon. Lack of national standards on AP provision, poor integration of AT in rehabilitation service delivery, and lack of funding towards research and context-relevant innovations on AT. Outcomes. You know, outcomes, at the end, what does rehabilitation do? Does it even have an impact in our lives? And I'm happy that the chairperson has really told us that through rehabilitation, is able to go back and play football and scoring for Parliament. Thank you, my senior journals, for providing the necessary rehabilitation. So, most of the government programs or sectors covering targeted specialized groups are lacking. For example, we have like stroke. Apart from the private sector, there is no other program covering stroke. Cerebral palsy, we don't have any. So coverage not equitable. So most of the people who need these services are not getting. For example, the elderly. We are still thinking of developing the programs for the elderly, but this is really lacking. And as we age, all of us are aging, by the way, and we will need these services. So either we lay our bed now so that we can enjoy it later on, or we reach there and start saying, I wish that time when I had the opportunity to change things. So it's an opportunity for us here to change things actually. Of course, financing is a huge problem, and of course data, because we do not have data, but we are working towards improving that. I will not look into this, but I will want to highlight the recommendations. One of the recommendations that MOH should undertake priority disability and rehabilitation health reforms, guided by the WHO regional call for action during strategic planning process. So to highlight this, RHABHS is already working with the Ministry of Health and the WHO to develop the strategic plan using the guiding tools from WHO. We need to strengthen accessibility, availability, and quality of rehab services, especially at district level, in line with universal health coverage. Many times we are talking about universal health coverage, but universal health coverage without rehabilitation means we cannot achieve it. Universal health coverage aims at leaving no one behind. And so if rehabilitation is not inclusive, then you are leaving so many people behind. And so we are not going to achieve our target. We need to revamp the rehabilitation infrastructure in the country. As I told you, the infrastructure is in a dire need. And I request that if you find time, do pay a visit to some of these units in the country. We need to integrate rehabilitation in national health workforce management planning. Of course, we know that Allied Health Council profiles all the rehab professionals, but when you look at the health workforce registry within the Ministry of Health, the rehabilitation professionals are combined as Allied Health. It doesn't come out who is the orthopedic technologist, who is the physiotherapist, so that needs also to be integrated. Of course, we need to undertake adaptation with national priority 80 list as per WHO approved the 80 products. Why would we need 80 priority lists? This is what NMS will be procuring like any other medical supply. It's called essential list. Of all the 80 that we need to have essential list, that the ones that say we must have this. And that's what we'll ask government to procure. As of now, we do not have one. And so even when you ask NMS to procure, you are only shooting your own foot. We need to enhance advocacy on integration and enhance funding for rehabilitation and AT in a wider health and non-health sector funding schemes. As I said earlier on, there is no funding for rehabilitation. We need to enhance the human resource capacity for rehabilitation in the MOH to provide a strong leadership and guide the implementation of the objectives of the National Strategic Plan. In the Ministry of Health, there's only one rehabilitation professional, one like this, and he's the commissioner. So you can imagine, he's the one overseeing the whole country. He's one like this. How do you even do it? So really, this needs to be looked at, and we need to recruit more people. And ideally, at the Ministry of Health, each of these professionals should be represented. We should have a physiotherapist, orthopedic technologists, speech. All these are supposed to be so that they guide the ministry in the planning. But currently, we only have one person. So you can see how the huge gap. We need to support and formalize the interim technical working group. Earlier last year, we inaugurated an interim technical working group for rehabilitation and AT. That is chaired by the public health, the Director of Public Health, Dr. Daniel. And so we need to formalize this and make it a functional technical working group. Allow me now move forward. What I presented is the findings from the staff assessment. This report is before the Minister for signing, and once it's signed, we'll be able to share it with all of you. But we have copies here that we are going to leave with the chairperson for before we can get the other one. So I would like to take you through what the RHABHS is doing and trying to respond to some of these challenges in the country. As my country coordinator had already talked about, RHABHS is a health system strengthening activity funded by USAID, and its aim or its goal is to support the strengthening of the health systems that are responsive to the growing need for rehabilitation across lifespan. When we talk about rehabilitation, we do not talk about disability. Disability is persons with disabilities are part of the beneficiaries of rehabilitation, but rehabilitation benefits everybody. So when we talk about rehabilitation, we don't say to children, but we talk about rehabilitation across the lifespan, from the time from conception, because even pregnant women need the rehabilitation as they prepare to deliver, up to where the life takes you. So to achieve this, we are focusing on three main objectives. We want to improve delivery and demand of quality rehabilitation assistive technology services at the community level. We want to develop the capacity of health system leaders, managers, and providers of rehabilitation assistive technology services. And we want to support the development and implementation of plans and policies for rehabilitation and assistive technology in the country. How are we doing this? We are working at a national and regional level, district level, and a community level. At the national level, we are focused on policy and regulation environment, evidence generation, capacity development, both at institutional level, institutional and individual level, institutional strengthening and technical working group strengthening, as well as HMIs. At the national level, this is what we have so far done. What are improvement of rehabilitation situation? We have just had the presentation, the key findings. We have completed the RATA. The RATA is a rapid assistive technology assessment. I highlighted you a bit of assistive technology, where we found that 25.5% of the population need assistive devices. That is part of the study, but it's still under analysis. We also completed policy and protection study. We have the findings, and we have written a policy brief that we want to present to the different stakeholders. We have gone ahead to integrate rehabilitation into the HMIs in our national DHIS2, and we have revised the tools together with the Minister of Health, and we are at a stage where we are configuring the DHIS2 and to print the tools so that we begin collecting data related to rehabilitation at the national level. We also are undertaking finance and economic analysis because we want to understand what does it cost to provide the rehabilitation services. What is the investment case? So for you to be able to develop an investment case, you need some information on financing, but also to cost the strategic plan, we need some studies on finance. We are, of course, doing workforce development, and we're engaging a number of different associations who are here on capacity development, and also revising the curriculum. We know that the curriculum is also outdated, so we're actually revising the curriculum for most of the rehab professionals, and we are happy that Allied Health Council gave us a lot of support and doing all this. Of course, we're also doing a study on club food integration. We want to learn that club food has been integrated to most of our health systems, and we want to learn how was club food integrated, and can other services be integrated like club food in our health system. At the district level, we are working to integrate rehabilitation at the PHC level. We want to see rehabilitation services provided at Health Center 3, Health Center 4, and the district hospitals. And again, we are doing demand generation. We want to improve referrals. One of the issues that affects rehabilitation is the referral, because you don't know where to refer the person in the community. So many times people move around, rotate around, and you end up with a lot of the traditional healers. Many people have lost limbs. You go with your limb, somebody ties it, because it doesn't know the physiology and anatomy. After 2 days or 3 days, your leg starts rotting. And when it rots, the surgeon has no choice but to cut it off. So many have lost because of poor referral. Of course, follow-up, provision and follow-up of AT. We know that our rehabilitation requires follow-up. Once you provide a service today, you need to know how the patient is benefiting in the community. So we also want to strengthen provision and follow-up at the district level, but also capacity development at the district level. Currently, we have done a lot of training And also we want to strengthen the HMIs. We have trained PHC providers in a number of districts, mainly 4, Mayuge, Iganga, Gulu, and Nira. We have trained medical doctors, clinical officers, nurses, as well as the VHTs. The VHTs, we have trained them to be able to identify people who need rehabilitation in the community and be able to refer. The primary health care workers, we have trained them to be able to provide basic advice on the rehabilitation and some basic rehabilitation before they actually refer to the regional referral hospital. As we wait for government, of course, to recruit other cadres to the lower facilities, we need to be doing something. We cannot just say that government, let's wait and see what happens. So we are doing something as government is planning to recruit the cadres in those facilities. At the community level, I already mentioned about this. We work with the community health workers. The community health workers, the VHTs, are a strong government structure. And so we are taking advantage of the existing structure, and we are building their capacity to identify and refer. We increase demand, because if they talk about rehabilitation, they will increase demand for it. Of course, we're also looking at how we can support them to provide maintenance for these assistive devices. For example, if somebody from Padel was given a wheelchair in Kampala, and after 2 years, the tire is spoiled, does that person need to come back to Kampala to fix the tire of the wheelchair? So we are trying to see how can we support the community health workers to be able to do some basic repairs of the AT. Because it's costly for you to travel a long distance to repair a device. Also, of course, we are building their capacity, and we're ensuring that data is collected at all levels of care. So basically, that is what we are doing. In terms of our approach, this is what we have based on the existing service delivery framework and structure. This is how we have decided to try out some of these innovations and see whether they can yield results. So we have what we call a network of care. Network of care simply means a defined population. So this population is can be a sub-county, a district. Okay, so we have networks of care, and each network of care we have community health workers, we have the primary health care workers, we have the district or general hospitals, but link them to the regional referral hospitals, the national referral hospital, as well as specialized centers. So at the community level, we are working the VHT. The VHT identifies who needs rehabilitation. And also there's the Qs, the community health extension workers, who are being piloted in Mayugi and Lera districts under government policy. So the clients and the caregivers play a role so that the patient is identified from there and referred to the nearest health facility. Could be health center 2, 3, or 4. From there, if the person who is there has knowledge of the service provision, will be able to provide assessment, provide a service, and then send the person back home. But however, if they are not able to, they should be able to refer this person to the next facility. So what we are trying to do is to strengthen the referral mechanism so that a patient knows where they should be, where they should go. And this should be in the back of the minds of the health worker, because the health worker should be knowing that in my district there is a rehabilitation service center at this point. That when the patient comes, you're able to say that, okay, for your problem, I cannot manage, this is what I can do, please go to this facility. So that's what we are trying to do as Rela BHS. And so at this moment, allow me to stop here, but invite my senior journalists to present on behalf of the rehabilitation professionals their prayers to the Parliamentary Committee of Health regarding rehabilitation services. Thank you very much.
Thank you.
Thank you very much. We have been joined by more members of Parliament. And as a chairperson, it gives me joy to have 16 members of Parliament grace this round. So without giving you the microphone, Can you please stand up and introduce yourself? We'll start from Kwanya district. A bit louder than that, Honorable.
Thank you so much. I'm called Chelain Betty Louke. The name Chelain means city. So Amudat is a city in Karamoja. So I'm the woman MP representing people of Amudat. That's in Karamoja. The people who are needed most in Uganda. Thank you. I'm a member of this committee. I'm a nurse by profession. I have other papers, but nursing is best.
Thank you. Good morning, colleagues. I apologize for the late coming. Had some earlier commitment. I'm Isaac Otim Giu. I represent the people of Badiere County in Nebi District, and I'm a member of this committee. I'm a nutritionist by profession. Thank you.
Good morning to you all. I'm Dr. Batua Timothy Rusala. I'm the Shadow Minister of Health. With that, I read the entire opposition on matters of health. And I'm also a member of this committee. Thank you very much.
The minister who doesn't have a lead car. Thank you very much, and I think now we shall proceed. But please allow me to use the chairman's privilege to insert another experience apart from the one of my Achilles tendon. I hope that rehabilitation with time can prevail over gyms and some of these massage parlors, because sometimes we get a lot of injuries and also misdiagnosis amongst practitioners. There's one particular place in Tinda where I went, I got another injury after the other one, but an adductor injury. And these guys were telling me I had a 3rd-degree tear of the adductor. And they did an ultrasound and they're telling me that is now blood under the tissue, you need to go back for surgery. I say, but how do I now explain that after a year I got another injury? But anyway, I waited after a month and did my personal physio, and it went. Assuming I didn't have some medical knowledge, because I read more about adductor. The adductor muscle is this one here. So I think I went for a high ball and I strained it. But they were saying I had, the doctors told me, but you would not be walking and driving if you had a 3rd-degree adductor tear. But at this place, they had done an ultrasound. I have the medical notes. Now, if I was an ordinary person, I would have been subjected to unnecessary surgery. So, these are some of the things that are going on in private practice, and we have to superintend over them. I hope the association, because there are a number of rehab centers opening up, and we don't know what is going on there. And people are being subjected to unnecessary procedures and surgery. So you'll probably tell us about the mischief that's happening. Thank you.
Thank you, Chair. Of the Committee of Parliament of Uganda. Indeed, what is trying to elaborate is pertinent. We have so many who are practicing as rehabilitation workers, mainly as physiotherapists, and they are mishandling our population. And In the long run, you find somebody, a case in point is also a medical person who went for a massage and they squeezed and he had a clot and his leg had to be amputated. This is a living example. He's a medical doctor around here. So the legislation is more than needed than yesterday, because we are allowing our population to get a road deal. And how has it come? It's because government has not been helping the rehabilitation professionals. We have so many issues at hand. Mainly, rehabilitation professionals are consistent of physiotherapists, occupational therapists, language and speech therapists, orthopedic technologists, orthopedic officers, audiologists, dental technologists, optometrists, and ENT clinicians. So this is before you, honorable members of Parliament, through Chair, these are the stakeholders of the rehabilitation professionals in Uganda. And our prayer is that our concerns should be taken care of and be implemented. And first of all, we need affirmative action with these prayers of ours. If there's need and you realize that these groups have been marginalized indeed as we are, we need to be given the support that we deserve. So in that aspect, there's an issue of leadership and governance. Here, leadership and governance, we are so much concerned of legislation, as the chair has elaborated. So many are practicing these professionals where they are not qualified, and they are doing harm more than good to our population. And here we need to create more rehabilitation departments under the Ministry of Health and at national and regional referral hospitals. Here we need some ring fencing of the budget. Honorable members, if this is to be realized, we need to put aside money, because what is happening in our hospitals, when they are making projections for the budget, these departments are requested to do the budgeting. And you find a unit or a department like physiotherapy, you budget 100 million or 200, but you will not use that money when the budget is passed. You find the maximum you can use is like 60 or 20 million per year. So it has been taken as a less privileged, not prioritized areas as far as rehabilitation is concerned. So when these and our equipment are very expensive. As the technology evolves, we use more sophisticated equipment. Before we were using shortwave, now we have shockwave, which works well for sports injuries and other related cases, and so many to mention but a few. So as technology evolves and super specialization comes in, you find somebody has been done a total knee replacement and he needs rehabilitation. This is a surgery which has taken over 20 million. But if you don't do rehabilitation, that person won't work very well, and the surgery will be wasted. So rehabilitation professionals should be accorded their due docket. Thank you, members of Parliament, for listening to us. Now, the issue of financing. Financing, we would like to appeal to you, members of Parliament, through the chair, when these assistive devices are given. Even some NGOs give free, but when it comes to revenue authority, the taxes they ask are so enormous. One time, there's one which was, they brought 1,000 wheelchairs, but they had to sell 200 in order to realize the taxes that were being demanded by revenue authority. So, as far as it is concerned, assistive devices, we need them to be given some due special line of tax exemption. And we are not saying that it should be a blanket, but there should be a way of how it can be handled. Because the concern of government, they will say people will just flood everywhere with assistive, but there is a national committee which is there to handle those who will be coming in, that whatever is coming in is to standard. We need standard assistive devices for our population. Then the national health budget, including the local government, be inclusive of rehabilitation and AT services. That's one I've elaborated. Now, when it comes to human resource, honorable members, through chair, we as health rehabilitation workers, we feel that we indeed you are quite marginalized. We had an epidemic of COVID-19. And what it was affecting mainly was the chest related. And on the task force, they omitted the rehabilitation workers, mainly physiotherapists. It was not until the complications set in, they realized that the issue of these cadres were more than needed. Because those ones who underwent rehabilitation, their lungs were, because COVID affected most of the lung tissues were so much damaged. And some could have as far as 60%, but when we did some activity pacing, that is allowing that patient to move slowly as the demands of her body could allow, and they picked up. So it was something which was realized later, and we need all the rehabilitation professionals to be given their due docket as far as Ministry of Health is concerned, if indeed, as my colleague has elaborated, that at the ministry there should be a unit for rehabilitation professionals. Now we have just only one, and it never came just on a silver platter. There was real force, not until they realized indeed, and there shouldn't be some like industrial action to cause change. There should be policies which could argument things to go in a proper way. Thank you. And as far as human resource, when it comes to the rehabilitation professionals, Mulago, when I joined, we were 25 physiotherapists. Now we are 11. the population is increasing. The new structure which came, they had even scaled them to 10. But we complained, and even the new professionals like language and speech, they have been put on the new structure, but the concern is the scheme of services haven't been. We forwarded through our rep, Professor Okilia, Allied Health Professionals Council, facilitated all the health professionals to do these schemes of service and the scope of practice, and they were presented, and we are waiting. We now have quite a number of graduates degrees, but they are not employed by public service because there is no scheme of service in operation. So the issue, even one time, the issue of trade-offs, you find now a department has 18. Now the administration takes it upon itself. They say, we need more of these cadres. Now, being that I represent physiotherapy, speech and language, you find that the numbers which were existing, it is a matter of attrition. You just feel those who have been promoted, those ones who have been, who have died, who have retired, instead they are traded off. And as we wanted to complain, they said through public service it is permissible. So we had nowhere to say to complain. Said the onus is on the administration. If they say these cadres are not needed, then they trade them off. So what happens is the most unfortunate professionals, the rehabilitation professionals, you find that they are more than affected than the rest. So that one is a big concern. Service delivery. Here, with our meager equipment, the good thing, through our professionals and international bodies, we've tried to keep abreast with the new modes of rehabilitation methods. That's why you find that even when one is handled here locally and he goes outside, finds that there is real relevance as far as rehabilitation here in Uganda is concerned. But now the issue of credentialism has come in, and rehabilitation professionals shouldn't be left behind. They should be helped to upgrade and get proper documents which can make them feel motivated. So the community-based rehabilitation services in Uganda was a model as far as community-based rehabilitation. One time in 2002, I went to Japan on that very program for 4 months training, and I was imagining what is Japan is a developed country. How is it community-based rehabilitation being applicable there? But to my dismay, even on their streets, they have technology where they design where a blind person walks along the pavement. It is designed in such a way that even when he has his walking cane, when he reaches at the traffic lights or zebra crossing, he presses for the cars to stop, and unaided he goes across. You see how far they are caring for their people as far as community rehabilitation is concerned. So it is not something which can't be done here. It has been done elsewhere. So rehabilitation and those AT devices, you find even those ones who are blind, getting that white cane is very expensive. One time, some years back, they were trying to develop a policy on AT, and the participants, the person, those with physical limitations, they said, for us, if you give me a walking stick, if you provide me with crutches, it is like you are providing a Panadol for me, because you've added the quality of life of that individual. But it is not catered for, even by national medical stores. They have no docket for those appliances to be imported. So those are things which we need to consider through the National Committee of Parliament. And a good thing we've seen, it is composed of our colleagues, mainly doctors, those ones with the health background. So we are preaching to already converted. The medical supplies, now when it comes to issues of glasses, these are things which are very expensive. And you find a child as young as 10 starts using glasses, and the family can't afford. You find that the treatment for such is, I have a nephew now, because of the allergy, his cornea is now destroyed, and it needs 3 million. In addition to that, he needs glasses. And these are young growing people. All across, when the rapid assessment was done in the country, as the technical person, we moved where we went, and indeed we found that most people can't afford even the glasses, other assistive devices, crutches, wheelchairs. And I think yesterday, honorable members, you saw a team of amputees who are going to represent our country in a football competition. The picture was there in New Vision, and these are young people who were unfortunate because of these rampant road traffic accidents. They found themselves there, but they need to live their full potential. So they are going to have that Paralympic football tournament, and these are our clients, because we don't call them patients, because they were involved in an accident and their legs were cut, but they are living normally. Once they are facilitated to move around, they live like any other person. So these are some of the medical supplies that our assistive devices need to be. These are mainly our prayers, honorable members of Parliament, the committee, and other prayers. We need to increase numbers of rehabilitation professionals. As the chairperson of the board, I was privileged to go to Soweto University. They are going to start a degree course in physiotherapy. Mbalala has already started, and they are almost 10 years, but the degree holders are not employed because the scheme of service is not yet implemented. So we need as we are happy that the government is helping the elderly on social security by providing a stipend, and at least that is in the right direction. And if they are even provided with the assistive devices, because now if you give 2.5 million and you find the assistive device, that person who is aged is going to buy, then you have not helped. But provide whatever is needed on that person, and once you give the money, you can use it for other things. Thank you. And honorable members of Parliament, these are our prayers, and we thank you for listening to us, and we pray that our concerns will be ably handled by you. Thanks a lot.
Okay, thank you very much, Mr. Jonas, and I think Gerard, and going by how they have presented, we can see that there is a gap. And going by the current saying of Twagara Sente, you've heard that saying, Twagara Sente. So, Vice Chairperson, thank you very much for taking a seat. Twagara Sente. I think that's what they meant by the presentation, but they are trying to hide behind, but they were saying Twagara Sente. And it's very important out and say Twagara Sente. Now, next on the agenda, we're going to have, I think we have 2 items remaining, and then we close this. But before we have the next participant, I think it's very important that we a little bit stand up and be a little bit active. Our chairperson is a footballer, so let's have a game around football. So let's all stand up for our next presentation. The game is around football, and it has been played. So let's have a ball, and then we prepare. So we're going to start by saying, I have a ball, I put it here, I prepare. I have a ball, I put it here, I prepare. I prepare. I have a ball, the big one, I put it here, I prepare. I prepare. Who I am, regular members of Parliament, stand up and prepare. But that said, let's have Dr. Okia from Allied Health Council is going to give us what they have done as far as their council is concerned, but also the gaps they are finding in the activities they are doing. Ladies and gentlemen, Professor Okia.
Say good morning, honorable members of Parliament. Good morning to the chairperson, vice chairperson, my old friend. It's nice and pleasure meeting you. I bring you greetings from Allied Professionals Council, where I'm the chairperson but not the president. Yes, I actually love that title, the president, but I don't know which dimension I should take to have it on my CV. So, honorable members of Parliament, it's a pleasure to come and be party to the professionals that you lead. Under me, I have 30 different professional cadres, 32. So I have a family of about 40,000 professionals. And the role of the Allied Professionals Council, which was established by an Act of Parliament, is really to register, regulate, and control the professionals. And members of Parliament, this is a big mandate for the big number of persons, especially with various qualifications. Allied professionals has come of age. originally, initially, many of the persons were certificate holders. Then the diploma holders came on board. And now we have a number of them that are and the skills and competencies, and they are now holding bachelor's degrees. Honorable members of parliament, it's also amazing to learn that several of those people, much as they name qualifications they started with, hold several degrees. I want to give myself as an example. I was employed as a dispatcher in government when I was already doing a PhD. But my salary was for a diploma. I was being paid and that was my employment status. So when I reached 45 years, I opted to go for early retirement. One of the things is that it didn't give me a living experience to continue in a redundant setting. That does not give you encouragement to grow and exercise your competences and skills as a professional. The rehabilitative cadres of this country fall among my set of actually under the council. As a council, we recognize that these essential services, they are not marginalized. But I think we are not fast to recognize them until we get into problems. We want always to cure. When these people come with the programs, that give us an opportunity to be able, can I do without to be able to provide the essential preventive services. No attention is given. What is happening currently now is that the rehabilitation services in the health sector tend to be for everybody. The honorable members have just been talking about the saloons that are run by anybody. The saloons now go and do what they call massaging, unmeasured massaging. The measure is, have you felt pain or not? And how much is the pain? Sometimes the more the pain, the better the massage. Now that you have started feeling pain, I think I am there. This is the extent at which we are. And we go appreciating these services. Because from the massage feeling a lot of pain, you come home, your mind is set that at least now the pain, but it's the one who can do the first pain. So why wouldn't you celebrate lesser pain? Honorable members of Parliament, it is a very critical thing for council. Currently, we have done 17 schemes of service, and some of them are for the rehabilitation cadres. These schemes of service are supposed to give a roadmap on what these people should be doing, are professionally entitled to do their career. But much as the council supported these activities, they have taken long to get approved. Every year, there is a review. Now, the new thing that is coming on board, I think which is taken honorable members of parliament attention, is the merger. I'll be moving with a family of 30 to join the nurses, the medical doctors. But within my own family, I still have a problem in keeping the identification of these cadres. I don't know whether you are going to move me and put me either the chief father or fathers in the merger. I don't know what this is. So we want to say the schemes of service for these professionals have been something that has been pending. it is there. But I know the biggest problem, honorable members of parliament, is probably now the financial implication. Can you imagine in the areas that you come, that government provides for only one person in a health center for? And some of your constituencies don't have health center force. That means that you have no rehab card, physiotherapists, occupational therapists in your constituency. Imagine the number of border accidents. Imagine the cases of gender violence in your areas. Imagine the aging population in your area. And you don't have anybody assigned by government to provide that service. There are a number of people who are qualified. But you can see the structure provides one place. And that means that if the next rehab person has to get a job, he must wish the other one to die. And even the provided space is so unfortunate that it has no career growth. If you are employed as a technician, you remain as a technician until you go away. It cannot be a career for anybody. Who else would want to continue providing services? As you are improving on your skill competencies, you are still held in the same position. This is not a good thing for any professional. I see the gaps provided here. In the villages, because of the gap, non-existence of these persons, the council has taken itself a responsibility, working with the association, to get a scope of practice for private practice for these professionals, to allow them to practice the skills and the competencies they gained for commercial purposes. And that has been on, and I'm sure by next year we should be having these professionals be eligible to open their own rehabilitation units as standalone. Because currently the issue is that they need to dig rehabilitation. Where are the owners of the knowledge? Okay. So we can no longer have
in this current generation. A situation where we have trained professionals and they are left out there without engagement, without provision of the necessary equipment to provide critical care services. We don't need to wait to get old and get accidents to get this. Honorable members, it is a critical matter that even to the extent that because of the gap in the rehabilitation and the care of these persons, we have even now a lot of engagement. I am a Christian myself. People praying for broken bones as a cure. Be healed. Receive it. And people walk. I don't know what percentage of the people who walk from be healed, because even the Bible is very clear about the healing process. You must be part of the process. If we get people to understand that they can be taken to an altar and told be healed without getting proper medical care, then you probably are misleading the population. I agree with the prayer 100% that God provides the overall power for the healing process of our lives and our. But for the physical injuries carnally here on earth, you must engage medical professionals, because they're the ones who have been anointed by God to handle care. Are we together? Yes. God works through persons, and these are the persons that have been enlightened, anointed, and given the competences and skills. For me as a regulator, I'll be very excited to have a bylaw or whatever it means that bars the practice of these persons in attempting to do what they are actually not capable of doing. The bone setters are good to an extent that you are dealing with a small sprain, to an extent that you probably desperate, but you cannot afford to be able to keep yourself under such a setting of a person who does not know. Now, what has happened in the practice as a regulator is they are now also beginning to mix it with the medical practice. Go for X-ray. You are taken for an X-ray, but the person looking at the film is not professional. Go for X-ray, go to the lab, but you don't know how to interpret. You don't know how to set the bone. Last week I was privileged to be appointed a board member for Terewode Women's Hospital, Fistula Repair and Rehabilitation Center. There were testimonies about the people there and the work of the physiotherapists in that center to rehabilitate these fistula women who have been repaired. But if you listen to the testimonies that the women had in their villages when they need that rehabilitation, you can just understand that the people traditional there would tell them to sit in pilipili, hot pepper, to stop the leakage. They would tell the mother who's leaking has the VVF or RVF to sit in hot pepper. And once you desisted, they hold you until the pepper burns you. And these are the people who are being rehabilitated by the people in our communities. Honorable members of Parliament, we have a lot of gaps in the service provision in this country. We are building capacity, we are building competencies of people, but the people are underutilized. The rehabs of this country have a great role to do now than ever before. You can't afford to have a structure where a district hospital has one orthopedic and one physiotherapist in a population originally envisaged to be about 150 or so, and now you are over 600,000 people. How do you provide a service? You cannot provide a service. We do support supervision, and you simply go and get broken beds in a rehabilitation center. The service facility itself needs a rehabilitation. How then do you rehabilitate a person if your service needs a rehabilitation? For me, it's painful as a supervisor and a regulator to look at this. It's a difficult scenario these people are having with. So their plight should be looked at positively, that they are honestly requesting to provide quality services. We have the issues of gyms and what. Many of these issues supposed to get a control and the health professionals to take over this. People have taken this to be health exercises places. I can assure you it's a very critical matter if we don't engage these persons to be able to man. 3 years ago, we closed a facility in Imengo, which was doing, which had brought some Chinese medicine. That they put pins on the whole of your body and connect you to a certain machine. And so that they disturb your nerve endings until they give up and the pain temporarily gets off. So, at the end of it all, there is some medical aspects in it. But basically, the way it was being used was that this can repair your bone. This can remove your arthritis completely. This can. These are unmeasured, scientifically not proven interventions. We need to put these people in the perspective of their profession and make them understand. For me as a regulator, I am ready to provide the regulation. I am ready to provide the licensing of these professionals to practice privately if government cannot expand and understand this is a requirement that we need in this country. We need the physiotherapists, we need the orthopedics, we need the orthopedic technicians, we need people to be able to get us these aspects. You cannot afford in a century where people are using air cast boots for accidents and people are using broken pieces of wood to mobilize fractures. And you are watching them and somebody is convincing you that even that wood has medicine. Tell me what mechanism is entering into the repair of the bone. The psychology is simply keeping the bone in position. But the issue of saying that the wood has medicine is outrightly wrong. Because if you said I could pick my wood, they say, no, this is a special one. This is a special wood. To keep you in his own wood, which you actually have in your backyard. So as a council, we shall continue supporting the professional council and be able to ensure that the profession is held at its esteem. I want to make a final call to my professionals. Never give up for your journey as a professional. Health services is a calling. You've been called upon to provide a service. I know among ourselves, there are also persons who have gone so extraordinarily to disadvantage the clients in terms of exorbitantly asking for money, because the rehab services tend to be lifelong or longer periods. And we have made these people come for reviews unnecessarily at a cost of their own. We made these people carry gadgets that are not deemed for their conditions. We have made these people get into some of the extra practices that could be detrimental to their health. I want you to remain as professionals. Remember that the provision of health services is not about money. It's all about taking mankind with humanity. You need to have this calling in you. As we complain, as we ask for government to engage in this, I know probably the part government can do. But within our means and competencies, can we always have ourselves together? The council is always available to give guidance, to give regulation on all these patterns. Take yourself as an association, as supervisors of your colleagues. Can we get the persons that are got in extreme behavior to the council for disciplinary action? The council will provide the leadership, the council will provide the mentorship. You know where the council has come from and where we are today. For the sake of the honorable members of parliament, I am actually serving my second term of office as the chair of council. We have 3 years, and I'm sure that the third term will come because I'm doing a good job for God and my country.
Thank you very much, Professor. I think another round of applause for Professor. And thank you very much for pledging support. It is very important. That support sounded very audible, and we are waiting for that support.
But that said, also thank you very much for campaigning for the third term. We promise that we are going to rally behind you and look for that support. Now, that said, we are into our last part of this meeting, and it's going to be some sort of Q&A, but also feedback session and remarks from the audience. So we don't have the microphone, but we will have to improvise with the mouth alone and then sound very audible. So if you want to speak, you're going to come here and speak for about 1 minute. That is in form of a question or feedback for all our participants that are discussants that have just talked. And then we move for our lunch. So thank you very much, sir. I will request that we introduce ourselves once again so that we're able to recall. Thank you very much.
Thank you, sir. Yes. Honorable Chair, all protocol observed. Beinom Onesmus. I'm a senior clinical officer, specialist ENT. I work with the UPDF Medical Services. I'm the director, Global Care, Uganda. I want to thank the RELAB for this opportunity they have given us, and I want to thank the Parliament and specifically the Committee of Health for coming to listen to us. Thank you. ENT clinical officers are part of the profession which is in Uganda offering services. However, just like other people have talked, we have limitation of ability to offer our services, and mostly the limitations we have are in the government sector. However, we have made it incumbent upon us and other professionals to go private. Most of the clinical officers of ENT are offering private services. However, we are finding a very great challenge which would want the Parliament to help us. Private service in Uganda, mostly for health, has become very high and very costly to sustain. It is so costly in terms of sustainability, that is human resource, that is employment to be specific. We look at issues of our equipment, very expensive. Mostly when you look at someone, a patient who happens to be born deaf or by any coincidence becomes deaf, and by diagnosis we find that we need a cochlear implant for this patient. It is not done in Uganda, but out of some initiatives, we tend to get professionals from the UK, and when they come to Uganda, a patient is charged 100 million to offer that service. Which people normally get these challenges? They are the poor and the least of the baseline. That is the cost of the inputs. When you look at the cost of running a clinic, just a private practice. A private practice today, when I open, I said I run Global Care, and under it there's a Global Medical Center which are everywhere. When you open one day like this, the council here will ask you for an APL for you. They have introduced another aspect called extract, which is a double replica that when I'm working in government and I'm offering a private service, I pay 2 licenses every year. Before you finish, there is a trading license, which was previously scrapped off when Honorable Mary Achambade was the Minister of Trade. But the local councils were wise. They changed from trading license to operational permit. They tell us now, you see, you enjoy our services here, and in those communities there is even no service unique that they offer, but they want operational permit. Before you know it, they want ground rent. Before you know it, they have introduced another one called the local service tax, which they want us to be charging from this. Every employee whom you are employing, you must cut a certain percentage and take that money to the town council. These nurses whom we are employing and other people, because of the nature of our services, you find they are paid little. They want you to chop. You go ahead and pay pay. You go ahead and pay NSSF. So a poor me, you find I have a lineage of around 10 taxes to run a private service. What happens is most of our members have given up with private practice, but which is ideally where most of our rehab services are provided. It is noticeable that whereas government is trying its level best, it is not yet good enough. Where I sit, where I side I work from, you find we need very many patients who need hearing aids because of the kind of operations they work. But you find that for a long period of time, you don't have those hearing aids. And where do people run to? Private practice. When they go to private practice, very expensive to get. So in that term, as Parliament, I would request you, please kindly, if there is any way, you can revise for us the taxes levied upon us to offer private practice. It could be of great advantage to us, to the communities, and to the nation in the long run. Without wasting much time, I want to add one point. Yeah, without wasting much time, the last point I want to add is about enforcement. Still the council, through the council and to the Parliament, true we have rules in place, but they are not working enough. Nowadays we are having a lot of political sabotage within our services. A certain herbalist sits in a village, gets some money, goes on TV, goes on radios, they start advertising freely how they can cure every kind of disease. And our patients in the villages and in communities, because they are desperate, they run freely to them. Even in the city, go for those local concoctions. Actually, they are not even local. They get those herbs, mix in drugs in unregulated doses, and our children end up getting hearing losses. Most of the children get other complications which are irreversible. And by the time they get to us, the ENTs, or the ENT clinic officers, you find we have nothing much we can do. But those people are comfortable in the villages, advertising every now and then. We are paying to the council a lot of money, which is supposed to be helping us screen out those people, but they are not. So it is my humble prayer that our honorable members, you can help us on those two issues. And I speak that for God and my country.
Thank you very much. I think for purposes of managing time, this is how we're going to do it. We're going to have questions and answers and probably feedback for 1 minute from the other side, and then we'll have the Parliament respond to any queries that might arise. So I'll start by the gentleman on the other side, then you'll be the second. Yes. Okay. Okay, perfect. Okay, the gentleman, we have 1 minute. 1 minute. Yes. Let's be very fast. 1 minute. Just 1 minute, sir.
Thank you.
Thank you very much.
Honorable Member of Parliament, thank you for this opportunity you have given us, the rehabilitation staff.
Thank you.
I would like to talk. Sorry for that. Member of Parliament, we have Ministry of Health. At the Ministry of Health, there are very many staff at the Ministry of Health. But as rehabilitation professionals, we have only one staff there right now. And the Ministry of Health, it is actually the policy formulation. It has the mandate for policy formulation, meaning these services are not going to be regulated. You have heard that some of the service provisions actually are given by you, the honorable member of parliament, by donating some of these assistive technologies in the communities. What does that mean? This assistive technology can be harmful. For example, if a wheelchair given to a child who has maybe had challenges with walking, this child might need something very small called an AFO, something to support the foot. But when you give a wheelchair, you might end up crippling this child in a wheelchair, meaning that we need rehabilitation professionals from up to lower levels. So when we don't have proper representation at the Ministry of Health, when we don't have a department, remember also at the ministry, these departments are costing units. That means rehabilitation, we shall not have a proper budget because we have one person, we don't have a department, we are always under different people. When you go to the regional referral hospitals, that also happens. We don't have these specialized department for rehabilitation professionals, meaning no budgets actually we shall come out. We just follow under Department of Surgery, sometimes we follow under Department of Community Health. In my hospital where I work, a good regional referral hospital, rehabilitation services follow under surgery. But at our budget for the hospital, it is prevention and rehabilitation services, and some of the things they want, the outputs in that sector, it is family planning, antenatal care services, not anything to do with rehabilitation. Health services provision in Uganda, they are highly decentralized, meaning at the national level we have regional, then we go to the districts. But at the districts we don't have rehabilitation professionals, meaning our people at the community walk hundreds of kilometers to access rehabilitation services. In other health services provision, people actually, the government policy is 5 kilometers for people to access health facilities. I work in Gulu, we cover Acholi, sometimes we even cover Lango, because it is Gulu which is facilitated by an IP. When we go there, you bargain with someone who needs rehabilitation services. Why don't you come? We shall provide maybe a free service to you. You say, I don't have money, I have to sell something, I have to sell my goat. And it's not actually, and it doesn't have the people to buy, it doesn't have someone to buy the goat. So these people are denied services because they have to walk 100 kilometers to access these services. And these are the very people who don't actually, rehabilitation means, when someone is rehabilitated, means that you have the capacity we are improving your function. But if you are not rehabilitated, you cannot function well, meaning you are economically excluded. World Health Organization has come up clearly and said every dollar invested in rehabilitation has $90 in return in the community. Because if you invest $1 in rehabilitation, someone will no longer be independent, will no longer be dependent on his relatives. That person will be able to empower himself economically, will be able to work. You have, among you here, I can see people with assistive technology like glasses. Some member of parliament, I know they have artificial limbs. I'm going to give you an example of one piece of polypropylene. It is used to make corsets, it is used to make artificial limbs. When we are buying it outside, you can get it at $50. By the time it reaches me to start using it to make, it is at $150. And who bears this burden? It is a person who is disabled, who is already not having financial support, who is not actually economically empowered to be productive in the community, but he has to bear all this burden. When you look at how much does the government inject in salaries, maybe water, sometimes and electricity, materials, National Medical Stores doesn't bring these things. They are left to private service providers. So you realize all the burden goes to these people with disabilities, and they incur what we call catastrophic expenses. They have to sell something of value to them. Thank you so much.
Okay, let's balance the agenda here. Madam, you can come. 1 minute, and then we'll have about 3, and then we have the parliamentary committee also have something to say.
It's unfortunate that we are having some persons with hearing issues, and so they can't hear what we are discussing. Protocol observed. Good afternoon, good morning, ladies and gentlemen. I'm Ruth Inaluja, the National Coordinator for the Spina Bifida and Hydrocephalus Association of Uganda. Honorable members of Parliament, I'm so very much delighted that we are speaking to you and the entire House. I just want to note out just a few things here. We've been talking about assistive technology, and it's like we are not talking about pharmaceuticals, which are used in rehabilitation. Personally, I'm a mother of a daughter with a spina bifida, and it's so painful that she's just in the hospital, so you will forgive me. For us to rehabilitate these children, we need some pharmaceuticals like oxybutynin to support them to manage the incontinence. She leaks 24/7. She cannot control her bladder. And in the country, we don't have oxybutynin as a part of the primary drug list. So members of parliament, my dears, I think these are the things we need to look into when we are talking about rehabilitation, which is a long-time care for children with spina bifida. And then some of the medical devices that have not been mentioned about here. My daughter uses catheters on a daily. She has to catheterize herself 5 times a day. And because in Uganda we cannot access catheters that she uses, we use like 1 catheter for 6 months. Just imagine 1 catheter in 6 months. And these are the things when we are discussing rehabilitation, we tend to forget. And when we are talking about continuous professional development, we forget about the VHTs, the caregivers that are supporting in the continuum of care to rehabilitate these children right back in the communities. So it's, I think, high time for us we started discussing about the continuum of care in its totality than just to concentrate on a few things. So I would be very, very much humbled that members of parliament from here, when we are reviewing the next budget, we look into the 18% that was put on Pampers. My daughter uses 5 Pampers a day because she cannot go to school without Pampers. And then we are seeing 18% on adult diapers. How are we going to support our children to go to school? All these are things that we are using to support our children, to rehabilitate them in their lifetime. So these are the things, ladies and gentlemen, that we would like you to really, you put on our shoes in a way. And before any tax, any regulation is passed, we do some really concrete consultations. What exactly is needed? Because I can no longer now afford the 18% tax on the Pampers, because I used to use 50,000 a week. Right now I need 80,000 per week. So, ladies and gentlemen, that's my submission.
Thank you very much. And now, Fiona from Taninga, what do you have to say? And then we'll have the gentleman in that suit, and then we will move. Yes.
Thank you.
You can't even stand where you are.
Stand here. Okay. Thank you. Sorry, I jumped in on all of you. Good afternoon, everybody. Honourable members of Parliament, thank you for the opportunity. Fellow allied health professionals, I'm delighted to be here to be able to speak with you all. My name's Fiona Beckerleg. I am a physiotherapist by background, and I've been in Uganda for 10 years as a member of the Allied Health Professions Council. And we've set up a Chininga Child Development Centre based in Western Uganda, where we're working with around 1,000 children with disabilities every month through a community-based approach. And I'd like to take this opportunity to really strengthen the argument for re-energizing and re-establishing the community-based rehabilitation program in Uganda. There is historical evidence that it was very successful in the northern districts many years ago and has since died off. There is a very comprehensive program at Chambogo University and also the Combra program where they're doing very much focused on the social rehabilitation, but I think with some adjustments there is opportunity to use the community-based rehabilitation graduates to meet some of the rehabilitation need at the moment, under the supervision of rehabilitation therapists to be able to work in the communities. We work in partnership with local health centre 3s because our families cannot get to the regional referral hospital where there are 2 physiotherapists based. Those 2 physiotherapists already have a whole hospital to provide services to both adults and pediatric cases. They don't have the capacity to reach into the communities, and our communities that we work with do not have the financial means to reach the regional referral hospital, and certainly not on a regular basis. Children with disabilities, as my previous speakers could tell you, it's not a one-time thing. Children need rehabilitation on a regular basis for years, and that is a lot of financial burden. So I think having people who are trained in the community inclusive developments that can combine the social rehabilitation with the physical rehabilitation is an essential way of improving access to rehabilitation in this country until we're able to get sufficient numbers of specialized and general allied health professionals at all levels of the community. So thank you very much. I hope that's my 1 minute.
Thank you very much. Thank you very much. Thank you. Awarding Julius, I think we have 1 minute. Everyone will have 1 minute. We have 6 participants to give their feedback, and then we go to Parliamentary Committee. Thanks. 1 minute.
Thank you very much. All protocol observed. I'm called Omoding Julius, a speech and language therapist by profession. I would like to expound a little more about this profession. This is a rehabilitation profession concerned with human communication disorders and swallowing difficulties. These specialists have been trained in the country for 10 years now, but they are not in our system. So let me take you briefly through the kind of cases we see. We see stroke cases, speech disorders related to stroke every week. With each of us is on average 5 people. So this is not good for the country, and yet these specialists are not yet in the government structure. So the patients who need us have to source for those services privately, and 3 of our MPs also used this service. And we thought by interacting with our legislators on this service, they would push the need for these specialists in our care system. But after getting better, they forgot. We handle stroke-related speech disorders, voice disorders, speech disorders as a result of traumatic brain injury, swallowing difficulties, stammering, and degenerative conditions. The list is very long. Of recent, we have had cases, speech disorders as a result of cancers of the head and neck, and then the speech disorders as a result of surgical procedures of tracheostomy, laryngectomy, tonsillectomy, and many others. On the new structure, these specialists have now been put there, but Mulago has been insisting on the diploma holders who are not trained anywhere in Uganda. So there are errors in that structure, and even then the numbers which are proposed are only 2. A whole national referral hospital. And yet these are badly needed specialists in the country. The regional referral hospitals the same. And then the other dilemma, the district hospitals where the majority of our people will go, they skipped this cadre in the structure. So our honorable members of parliament, having listened to this, we request you to look into this. Then the other dilemma is when the Allied Health Professionals Act, the principal legislation which controls these specialists, was passed, it is skipped this cadre because the training had not yet started. So we request that you prevail over the principal legislation on this principal legislation to include the cadre. And then the other pressing need, we are not allowed to operate private clinics. People come to us. If we are to operate privately, they tell us to either work under the doctors or the other rehabilitation cadres which are in the Allied Health Act, like our counterparts, the physiotherapists, the occupational therapists. So our hands are tied that's why we are not visible in the community. We cannot operate clinics of our own. So in the meantime, we request you, our parliamentarians of the Health Committee, through the Minister of Health, to issue a statutory standing instruction to allow speech and language therapists practice and practice independently. Then other things, harmonization of the structure for these specialists is very crucial, because as I've explained to you for 10 years now, these are highly demanded driven services, but we are not in the system. As a result, many of our colleagues have left the country for Kenya, USA, Canada, and yet we need these people here. We are hardly, in our records, we are hardly 200, but already there are many have left the country. So something has to be done about this, so that we have these specialists offer the services to our people. Thank you very much.
Peter. 1 minute, Peter.
Our dear MPs, protocol observed. Good afternoon. Yes, please. Time. Thank you very much. I would like to start by quoting the World Health Organization status report on hearing 2021. Currently, we have 1.5 billion, which is 20% of the global population living with hearing loss. I am Peter Lakony, Musimenta, an audiologist from UAMS Mulago. We have, by 2050, it is expected that there could be over 700 million people living with disabling hearing loss. That means by 2050, we shall have, in the hearing measurements, we shall have 700 million people with mild hearing loss problems. And nearly 80%, this is according to WHO, status report on hearing loss 2021, nearly 80% of people living with disabling hearing loss live in low to middle income countries, which Uganda is part of. It is important, I would like to bring in two issues particularly. If we could have a collaboration, because people with hearing loss are cross-cutting, right from children, newborn, because we are supposed to have newborn hearing screening, right to the oldest person that you can name. If we could have collaboration between Ministry of Health, Ministry of Education and Sports, Ministry of Education and Social Welfare and the elderly, because many of our beneficiaries and clients are along those areas, to network with schools, health institutions, and these organizations which are specific, so that we can be able to help, to screen, to ascertain the level of hearing challenges that are in those different age groups. It could help us to be able to deliver service. However, there is an access problem. Still, according to that status report of WHO, they say there is a service gap of 83% of those who need the services and those who are getting the services, which means 83% of those who need our services, who have hearing loss, are not accessing the services. That's a very big problem. I will give an example. A hearing aid, one of our wonderful members here has a bilateral hearing aid. These are equipment that are used to amplify the level of hearing. One piece alone is 3 million. A pair like his is 6 million shillings. Now we are talking of Ugandans who have meager earning. Many people come with a problem. However, after you've diagnosed them, after you've realized the problem, they just walk sheepishly away and die with their problem, which increases over time. That is a very big problem. We need to address this, our dear honorable members of parliament. we have an access problem here also to the communities. Many people will assume they will assume other, Professor alluded to using other methods, probably traditional methods and other methods which we don't yet understand, and they complicate their hearing challenges. If we could have means and support to have probably regular periodic access into the communities at different levels, we would be probably, when the MPs are going for their different meetings, they could include some of us to come and be part of their, especially now that we also have the health committee represented here, to come and elucidate on some issues to the community to help improve services. I would like to thank you. There are many issues, however, many are cross-cutting, which have been mentioned. Thank you for listening.
Good afternoon, members. Protocol observed. I have some concern. We are talking about lack of data. How long does the country remain without data? And yes, we have MPs. I'm happy MPs are here. As we are looking for voters in your constituencies, find out how many need rehabilitation is having. Because you cannot plan when you don't have data. So MPs who are here, represent us in your constituencies. Because me, I'm representing person, I'm a constituency of person with disability. But now you ask the honorable member of parliament, how many persons with disability in your constituency? Some of them they don't know. So I appeal MPs who are here, when they go back, talk about how the program of data is included in their program as they are going, as they are sensitizing in their communities. Food. Professionals who are here, have professionals. I appeal to you. This has become monetary where we go. Because persons with disability, where I'm representing, majority we are poor of the poor. Because like now, because I have condition of cerebral palsy, for example, majority of my colleagues cannot afford professional fee to see a physiotherapy. Because you need to pay, you need to find me in my clinic where I am. Let us become Ugandan. Let us not become individual participants. So that's my concern. Another one, I have seen the list of professionals. You have forgotten one for CBR workers. You cannot do any professional. You cannot be a doctor or a physiotherapy, whatever. From the community where you are born, where that person of disability stay, where that accident has happened, you can't know. So we need to recognize the potential of CBR workers in our community. Because where I'm working from, we train community workers, whoever. Like 2 months ago, I was in a park. I'm happy I've seen the MP from there. How we have moved the whole country, but our people are not recognized because of this professional. So I appeal to you. We need to work a collaborative effort, so that we attain one goal. Also, let us not be sister-centered, Kampala-centered, Mbale-centered, Ntungamo where I come, Ntungamo-centered. Let us go back to our place where we are born. Those people are staying in the remote area. But how many professional physiotherapists can go to work like in Nakapiripi? How many can go back and work in Ntungamo where I come from? We want to be in Kampala. We want to be in Entebbe. So we need to be. So also politics, as I conclude, MPs who are here, we have been passing politics, but how many people know them now? Our people we are presenting. People, most of our people don't know how to use and write. Our people, but how many can translate those policies into how people can understand them and they are able to advocate and lobby for those services. Otherwise, you cannot know what you don't know. So, members who are here, let us work together to see. If I meet a person in service, you will get it tomorrow. I'm not threatening you. Every person must get a service at own age. Whether you are so good today, tomorrow the aging will bring you. So let us prepare ourselves for that, so that we make our country be prepared for. If we can prepare for the flood, if we can prepare for refugees, why can't we prepare for our hub in our country, so that we see what has happened? So remember, thank you for coming. You take that information to our people in the parliament. If you are from a sort of ministry, if you are from another party, the service has no party. The service has no party. We need to work together as a team. Thank you.
Thank you, Chairperson. I am Dr. Patrick Ojok, Senior Lecturer at the Department of Community and Disability Studies, where I am also the head of department, and here representing the Dean of the Faculty of Special Needs and Rehabilitation. I'm very delighted for this discussion taking place, and I stand to make a few contributions. Although the presenters rightly said that rehabilitation is not all about disability, I'm lucky that the microphone started functioning when I'm here. Although the presenters rightly said that rehabilitation is not all about disability, I want to extend that statement by emphasizing that persons with disabilities actually have a greater rehabilitation need than other persons, and that should be a very important point to be mentioned. Second, I want to comment about the approach to rehabilitation that we adopt and promote as a country. Listening to the talk, I think that we are talking much about a medicalized approach to rehabilitation. When you looked at the list of the rehabilitation personnel that was displayed, there was no community-based rehabilitation personnel. And that raises the question, who is a legitimate rehabilitation personnel in Uganda? When you flash back to how community-based rehabilitation came into being, it was championed and coined by the World Health Organization. And so it was an approach to providing rehabilitation using a more low-cost approach, as opposed to institutionalized rehabilitation, which is quite expensive and which is Western-oriented. So I think that community-based rehabilitation needs to be accorded space on the rehabilitation table. And I'm here to ask that this conversation should be started. The second thing about it is that I want to call for a holistic approach to rehabilitation. You see, as Ruth, a mother of a person with disability, said here, when you rehabilitate a person with a disability by providing an assistive device, for example, this person the device may not make sense unless certain conditions around this person, the barriers around this person is broken. Let me give you the example where you have a wheelchair. You want to go to school, it has rained, and the road to the school is wet and full of gullies. Where will you maneuver your wheelchair for? The second thing is, even when you have a wheelchair, for an employee, who is coming to school, that wheelchair may have to remain at the doorstep if the access to the office is only stairs without ramps. So this means that in addition to providing rehabilitation devices, there should be accessibility issues that are addressed. Chair, let me recall a short story which I documented for Uganda Society of Disabled Children in Western Uganda. In one primary school there, I met a young boy in primary 6 who has a physical disability. So he was commuting 5 kilometers to a primary school. His wheelchair would break down and sometimes cannot go to school. And then between the school and his home, whenever it rained, his village is cut off. So what happened? His peers of 4 decided that they would help this boy to carry his broken wheelchair across the gully to the school. So even when the wheelchair was working and it rained, they would not manage to push the wheelchair to the school. So these formed a social support around this boy, and they would carry the boy to school. And when I asked them, why do you do this? Because even if that boy missed school, all of them would miss school because they wanted, their answer was that we want him to also be like us. We want to succeed together. So let us discuss rehabilitation within a continuum of services that must be addressed. If you hire an employee in the workplace, for example, somebody who is blind, and you do not hire a sighted guide for this person, you have not addressed the problem fully, because this person who is blind may not travel across the country for fieldwork without somebody who is sighted to help this person. And there are many organizations that are facing this problem. You are hiring a person with disability who needs a personal assistant, but your employment structure does not consider a personal assistant for this person. So this is a barrier in itself. The other issue that I want to end with is that persons with disabilities incur much higher healthcare expenditures and out-of-pocket expenses in order to attain the same standard of living as persons without disabilities. And this is a hard reality that we need to handle. And among them, they are poor. Actually, the multidimensional poverty among persons with disabilities stand at 90% versus 57% in the general population. So they can't even afford the health care that they need. They can't afford rehabilitation services. So it is an issue that really those who appropriate funds need to look into. So I stand here to say that, one, rehabilitation professionals start to open up to the conversation of considering CBR on the table. Let us adopt a holistic approach to rehabilitation. Medical rehabilitation in and of itself is not enough, but we need the other social dimension and so on. And finally, let the issues of higher expenses incurred by persons with disabilities to meet the same standards be factored into budgeting and appropriation of funds so that they are not triply disadvantaged. I thank you so much.
Thank you. Once again, I'm Edmund Chintu. the Council Representative for Orthopedic Officers and Technology at Allied Professionals Council. Mine will be a simple discussion, and I'll rotate around what the chairman said, because for us we are regulators, and the issue of regulation is still lacking in ATs. When we talk of assistive technology, assistive devices, we talk of wheelchair, corsets. In your constituencies, you have people who have had back injuries, and they need supportive devices to support their backs. Those are called the corsets. And then the same people need the physios to help them, the orthopedic technologists to provide the corsets, and other professionals, because rehabilitation, you work as a team, it's a rehabilitation team. But when you look on TVs, you see these pastors, they assemble all those devices. They are there. We don't know where they pick them, because there's a problem in regulation. I request Parliament to help my chairman to see that the Minister of Health, endorses the private practice for orthopedic technology so that we can regulate these devices. You go to Katwe, everyone is producing wheelchairs. Those things need people who understand them, the measurements and everything. They are technicalities. You're getting my point? Then the other thing is these people who import. We have NGOs, they are very good. We appreciate. But some of them are just dumping these things into our country. Artificial hands, which are no longer even functional. Some of them are not functional. They take them to northern Uganda, West Nile, where they don't come to Kampala, they fear, because people will know. They're just dumping them. Then you ask yourself, who is analyzing the quality of these assistive devices? You're getting my point? I feel bad, really. They assemble our people in villages with an artificial hand which was used in Europe in 1900. Things have advanced. I have my colleagues here who have gone to Europe for these advanced courses, and we have new technology. We have what we call the 3D printers. When you talk of those corsets, when you talk of the sockets, when you talk of artificial limbs, we have 3D printers. You just put on the machine and then it will print something very well. But we are still fidgeting with our local technology because we have not got enough scholarships to advance our knowledge. The loan scheme, when we talk of loan scheme, we have not had people accessing loan scheme for people in the rehabilitation sector. When you want to open up these bachelor's programs in universities, they will tell you from a diploma, you want to do a bachelor's, we need someone with a master's to be a lecturer. And we have none. You want to Minister of Health, please give us some 2 scholarships. We don't have. They will give the ones for malaria, for the what, but for rehabilitation is 0. So members of Parliament, please help us to see that we can have at least a few scholarships in these different professions so that we can have our own lecturers. It is very expensive to get someone from Europe to come and lecture in Uganda. Then I thank the Parliament for passing the sports bill. Please clap for yourselves. But I have looked in that act, I'm looking for an element of sports medicine. You know, I'm an orthopedic technologist and also I specialize in sports medicine. I have worked with football, different teams for over 10 years. And now I'm the current president of a baby federation called the Federation of Uganda Tug of War Federation, pulling a rope. And you Parliament, you brought that sport. I have talked to my brother Jonas. Invite us to teach you how to do things. I heard that we are losing. When you go to parliamentary games, invite us to give you the skills and we win. Yes, because we win in other sports. The Sports Act is lacking the element of sports medicine. We have my contact. I'm going to give it to you. We have seen people masquerading on those teams. I hear a physiotherapy assistant. I hear I'm a sports doctor. I hear what? But we have our professionals here. Physiotherapy, occupational therapy, technology, orthopedic officers. These are people who can ably work on those teams. I tried to register an association called the Uganda Sports Medical Workers Association. And it failed because most of the people practicing are crooks. You got them for the meeting, they cannot come. And I need Parliament to give me a letter so that I can use the word Uganda Sports Medical Workers Association to regulate this sector. We are dying. We are losing a lot of people due to injury. Then when I'm finalizing, my issue is concerning the different conditions that can be managed through rehabilitation. You know a condition called scoliosis, where you have this back bone, it should be curving from up here, it goes inside and it goes at the back. But sometimes it goes on the side, a bango, you call it a bango. And someone gets what? Sometimes they get kyphosis, sometimes scoliosis, it bends the other side. These are conditions who can be managed conservatively. When these kids are still young, you don't need surgery. But when you go to these private hospitals, they tell you, you need here many millions, you need to cut here, cut there. These are things which can be handled in the rehabilitation clinics or departments. I have when I talk about this, I feel very bad. I have my sister's little daughter, she's 10 years. They called me, you know what, you're in Kampala, you are Musawo, help us. This kid has problems with the ears. I took the kid to Mulago. I thanked the ENT team. They checked everything. They told me there is this test. You have to do it in a private something. We don't have the machines here in Mulago. Going there, we paid 120. They checked. Went back to Mulago. They told me this kid needs, what are they called? Like what my brother has. Hearing aids. And each one of them, they told me 3 million. That is 6 million. The mother is in Saudi Arabia. When I told her that, she cried the whole night. She's struggling to hand. I don't know, is it 1 million per month or what? 6 million. And the thing is not lifelong. After some time, you have to buy here. The battery is what? Please help us. Okay? Then when I was working here some time back, there was a kid, not even a year old. They had to amputate the kid's hand. The kid had a fracture. Then they took the kid to these bone setters. They applied the POP. You know, they buy it. And then the thing was not put right. By the time they brought the kid to the hospital, they could not save the hand. They had to cut it off. These are the sad stories we are fidgeting with in rehabilitation. Then I was in, for this Rata survey they talked about, when you went to some districts. I was in Rakai, Ruengo, Karungu, Masaka. There was a gentleman, he was around 56 years. He's the chairperson of the people with disability in that district. It is in some village in Ruengo. In Ruengo, there's some village, I'll give you the details. This gentleman was born crippled, and he has been using his local stick for walking. Then after using it for so long, the guy fell down and then fractured the same crippled leg. Okay? And he told me, for me, I have never accessed the crutches, the ones I need. Even I don't know where to get them. These are people in our communities. And you are the ones who can save them, to see that if we can pass our proposed, the National Strategic Plan on Rehabilitation, if it can be endorsed through the Ministry of Health and other stakeholders, then we can have these services up to the last level of our communities. All together. So, I think I have said everything. And I thank you very much for listening to me. Parliamentary Government team, please look for me. I don't want us to lose in the coming games. Thank you very much.
Thank you very much, Edmund. You have said everything. Now I'm going to request the next three speakers, whatever has been said, you don't repeat. You just say something new within 1 minute so that we manage time. Thank you very much. I'm going to invite Justus. Isaac, you line up if you want, and Elizabeth. You come at once so that they don't cheat you.
Good afternoon, ladies and gentlemen. My name is Justus Bohitia. I'm an occupational therapist, a senior occupational therapist, working with Kabale Regional Referral Hospital, and I'm a president for Uganda Association of Occupational Therapists. I'm glad that you have given us your attention today. We've been longing for it. Member of Parliament, can we please appreciate them? Thank you very much. We've been longing for this because we've been having burning issues for a long time. Basing on my background as an occupational therapist, this is just a little bit of what we do. When you get an injury, or when you get, for example, just give an example of a client or somebody, like a driver, taxi driver, falls into an accident and is amputated. Amputation is the removal of one of the limbs, maybe the lower limb. And that's the only job he does for survival. Behind him is a line of people he takes care of. How is he going to survive or take care of these children or his family? That's the only job that he has. So the occupational therapist begins right out from after surgery. And then you have to design his lifestyle. You have to look at a new way of life. You have to adapt his environment, change his environment. It can be any condition, stroke, mention them. But you have to see how best can this person become active and productive in another life? Or if not, how can we give special equipment or adaptations, the one who assistive aids or assistive technology, to use, for example, artificial limb or artificial hand to function the way it used to? If we're using computer, how can we design a hand through our colleagues now? Because we work as a team as rehabilitation workers. How can we train this new hand to function again? That is our role as occupational therapists. We use activities to bring health or to restore health once again. And this cuts across every one of us inside here and outside. We are here because we are occupational human beings, occupational beings. If it was not activity, we wouldn't be here. But these activities can be hindered by a disease or any dysfunction, which may be before you are conceived, you had it, it is inherited, or you can acquire it along the way. So now, having such a picture, and you have professionals who have been trained since 1994, they are in this country, but they are lagging behind. They are just lagging somewhere. There's no provision for them to be employed adequately. Even when they are employed, the environment is not conducive enough for them to operate. And then another thing is that where each one of us works, the environment must be friendly. And I'm glad that our government has policies in place. We have our laws that regulate most of these things. Just my last point, I want to put that in transport sector. Once we have done this, we worked on this patient who is from the hospital, and has to go back to his own environment, and he's a wheelchair user. How is he going to use a boda to reach his home? How is the road made? Accessibility. How is he going to access his garden? So all those issues. So each and every department in this country must be worked on, in that everyone who gets a functional impairment accesses his job and he functions in that environment with no hindrance. So I thank you. I don't want to add on. The rest have been said. Thank you.
Good afternoon, members. All protocols observed. I'm called Kakoza Isaac. I'm a physiotherapist by profession, and I'm currently the president of the Association of Physiotherapy in Uganda. As physiotherapists, maybe just to briefly let you know what we do, we basically focus on promoting, restoring, and improving movement when you have lost it, body movements when you have lost it, through maybe injury, illness, or disability. So the process of restoring it can take a lot of things. Maybe it could be relieving pain, could be mobilizing a joint, it could be even providing and teaching you how to use an AT. Now, you have heard so many people talking about masqueraders, and many of these masqueraders actually, they are within the circles of physiotherapy, because physiotherapy is the fastest growing rehab profession in Uganda. Actually, we have even bachelors, we have bachelors, people who have bachelors, we have even masters. But as a leadership of an association, we thought the most effective way of controlling these masqueraders is for us to form a society. Like you hear pharmaceutical societies, you see them on TV, maybe sometimes they go and even have the powers to close the people who are masquerading, selling drugs, isn't it? We believe also when, as an association, we become a society, it can help us to cap down the masqueraders so easily. But we realize that it requires an act of parliament to become a society. And as an association, we are trying to push for this. Very soon, maybe we shall be coming before you. And I believe when we come before you, you will be able to quickly recognize us and help us to push this. I will not say many other things that have been said. They have been said. So that's the main thing, which when we come to you, please, to help us form a society, please, please, please give us that assistance. Thank you so much.
Good afternoon to you all. My name is Elizabeth. I am the President-elect of the Optometrist Association of Uganda. Optometry is an eye care profession. With regards to rehabilitation, usually we are involved, for instance, when a person might be legally blind, due to a very high refractive error, they need a pair of spectacles. And once you give them a pair of spectacles, they become fully functional. More to that, there would still be people that are legally blind because they do not have, they are legally blind and there is nothing much we can do about it. And therefore they need assistance to use the little vision they have left. They might be legally blind, but they have a little vision left. And now we want to maximize, how do you maximize the little vision you have left? Even if you're blind completely, how do you become functional again after losing your vision? So that's where the optometrists come in. I would like to bring up the issue of legislation, but from a different angle. We usually get many people coming in, let's say, to do an eye camp. Maybe they came from abroad and something like that. But recently, for instance, in Lira, where I come from, there was an eye camp, they did a surgical camp, and then after that, people lost their vision. Because these people do their surgeries and all that, and then they fly back out. Then they leave the local doctors there to begin handling such issues. And then now we are getting more people that are needlessly vision impaired, and now we have to rehabilitate them. So just wake up call to the legislators to just kind of pay emphasis to that. And then also, of course, there are quite a few mushrooming optical workshops and all that, but then the issue is we get late detection of eye conditions, and then people still end up needlessly blind, and then we end up having more people to be rehabilitated. Then on the issue of infrastructure and recruitment at the different levels, one very important thing for us is that once we get these people placed in these different levels of government, that means that we also have more training ground for the professionals that we are trying to train and release out the students at the bachelor's level. They can now rotate on these different stations at Naguru, let's say at Mulago, but the issue right now, even if we wanted the students to rotate there to produce more rehabilitators, we do not have people to supervise them at those different levels. So just more emphasis on the need to recruit people. And also with eye care, we usually get an issue that we have very many NGOs that are related to eye care. So usually once you begin to try and engage, let's say, the hospital workers and management on trying to do this and this for the eye care, usually they tell you to get in touch with an NGO. There's a lot of support, but the government does not actually invest in eye care, so that puts our people that we are serving at a disadvantage. Thank you so much for the opportunity.
Good afternoon, everyone. Thank you, Chair. My name is Emi Semakula. I'm a senior orthopedic officer working at Mulago National Referral Hospital, and also the President, Uganda Orthopedic Officers Association. I want to welcome our MPs. Thank you for giving us time. Orthopedic officers, they are mid-level health workers who are working on patients with the neuromuscular skeletal disorders non-operatively. And we actually work mainly in general hospitals, regional referral hospitals, and national referral hospitals. Many issues have been handled, but I want to talk about this issue about pay as you earn. We find that health workers, of course, we are paid little. You find someone is getting around 2.2 gross pay, but the pay as you earn is around 30%. And we want you actually as members of parliament to see that it is reduced to 10%. His Excellency the President, I remember some time back, requested parliamentarians to discuss on this bill, but I think as members of parliament you have quite a lot of issues to handle, but we request in the next financial year, 2024-2025, please don't forget to table that bill. Secondly, I also want us to create more awareness about rehabilitation professionals. I want to tell you this, that many of people in the top offices, including parliamentarians and even at different ministry levels, you find that they don't know these allied health professionals, what they are and what they do. So please, you may find that someone doesn't know with an orthopedic officer who is an occupational therapist, and they don't know what we are doing. Please, since now you've come in touch with us, please ensure that you create awareness. And also, I'm requesting the professionals, if you work on these patients, when you work on a patient, please explain to the patient that I'm so and so. I'm an orthopedic officer, I'm a physiotherapist, so that these patients, they stop calling you doctors and nurses, because that's what they know, and that's what you want to hear. Please let us explain to these people so that they understand our services and who we are. Thank you so much.
Thank you very much. Thank you. Now it's time for the Parliamentary Committee to have feedback. Yes, you can come and hold the microphone.
Thank you very much. Once again, I'm Dr. Rutahigwa Elisa, and I represent the people of Rukunjiri municipality. I first of all want to thank the organizers and the funders for this engagement. I was wondering, because we are sharing a lot of information, and if it was not important, maybe I would have left. I actually had to cancel 2 other engagements, because what we are discussing here is very, very, very important. My only disappointment is that Minister of Health is not here. And I thought, but I quickly also think that because of lack of this department for rehabilitation at the Ministry of Health, may be the same reason why the representation from the ministry is not there or minimal. I'm told you are from the Ministry of Health? No, they are not here. So I think that could be one of the reasons. But I think even my colleagues who are here are very happy to share with you the professionals in rehabilitation. I want to tell you, I worked at the Ministry of Health before I joined the Parliament, and we were implementing a project, result-based financing, RBF. And we are encouraging innovations for which the facilities would be incentivized. We had everything. What we are talking about is equitable accessibility to health services. And of course, you know, services here in health services in Uganda are supposed to be free, at least in the public facilities. So whoever walks into the facility with malaria should be treated. If you come with any disability, you should also be attended to. The way a patient for malaria is referred to a higher level should be the way somebody with disability is also referred to a higher level. But because of lack of human resource at different levels, because of lack of equipment and other requirements, it is very difficult for someone with a disability. I'm very much, of course, disappointed with the Revenue Authority. You know, these taxes which they put on ATs, assistive devices. I mean, if you cannot tax paracetamol or other medical equipment, but you want to tax what? These ATs. I think it is a very big disappointment, and I think we shall definitely talk to them as Parliament. But not take a lot of time. And just because Minister of Health is also not here, I would want to make a request that all these different professionals should make their report, should put their points clear to us, to Parliament. It can be in form of a petition where the Parliament will now be able to sit down, because we can ask Minister of Health to come and we sit together and have a discussion so that we come up with some everlasting solution. I have been in practice for many years, and I've seen patients being escaping from hospital when you go to Mbarara Regional Referral Hospital is supposed to handle all these fractures and the rest. You know, but nearby, as you cross Ruizi, there is some traditional man, you know, who takes care of such a patient. There is another one in Kabgohe. You know, there is a patient I followed in Kabgohe. And in my presence, the patient died. So he got an emboli, you know, and had a fractured femur. So he was just being mishandled there. I think there are very many issues, honorable colleagues. Just put them. You have had many of you are presidents. You come together, look at each professional, if it is ENT, if it is speech therapy, put down what you really want to do for Ugandans. And then we shall discuss with the Minister of Health. If it comes up, if there is a need, we must legislate and make sure that we save the life of Ugandans. But my colleagues, let us thank these people, let us thank the organizers for calling us to listen to you. I want to move. Thank you.
UBC, inspiring Uganda. Pick of the day on UBC.